on this episode of A Tale of Two Hygienists.
So we want to see what are our original probe readings, what's considered the norm for this case. And if the patient comes back and we disclose and there's no biofilm, so we're thinking guided biofilm therapy. If the tissue looks pink and healthy, we disclose we don't see biofilm around the tissue. We look at x-rays, we don't see change in bone. I don't feel compelled to probe that patient. Boy, and as a hygienist, you want to go in there and you want to probe. I mean, we want to do this, and you almost feel like you're not doing your job not probing. But if you're going in and aggressively probing every time you see this patient, you could be detaching the buccal attachment. You could be causing more trauma than good. We now know all instruments will leave some kind of residue of its metallic, of its plastic behind. So you really do want to use a biocompatible like material on the implant surface. So if you're going to engage and you're going to scale a titanium instrument, we'll leave a biocompatible trace behind, titanium on titanium.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.
Welcome back, listeners, to another episode of A Tale of Two Hygienists podcast, episode number 463. My name is Andrew.
And I'm Annie.
Yo. What's up, Annie?
Not a whole lot. Getting really excited for Thanksgiving this week.
Yeah. I mean, happy Thanksgiving, everyone. It's
Yeah.
tomorrow, technically. Allison and I and the kids, we all celebrated on Sunday
Okay.
because we were going to be gone. There's the Greater New York Dental meeting that's coming up. And so, we knew we were going to be gone. And also we didn't do a turkey. We did a chicken.
Oh, you did? Okay. Hey,
I don't know.
I'm all for like different traditions. That's cool.
What are yours? Do you guys do anything unique or interesting, or you guys pretty much like turkey and cranberry sauce
we
people?
do. Yeah, we do like all the traditional stuff. Although this year my mom was like, let's get In-N-Out, or like, let's do Chinese food or something. But then all of us were like, no, we don't want to do that. We want the normal food. We have it once
actually
a
sounds
year.
pretty good.
I know. Like we have this Thanksgiving food once a year. And so she's like, okay, fine.
Do you normally have it at your place, or do you guys go like share houses to
Yeah,
different?
we're not hosting it this year. We're going to see, we're kind of meeting some family halfway between here and Southern California. So, yeah, it'll be nice.
That's not bad. I mean,
Yeah.
it's been years and years and years, but Allison's family, that was like their big holiday. And so
was
it was,
it? Okay.
it was like, the holy grail of holidays. And so they took it really seriously.
Oh, wow.
But then when her parents handed it off and then we moved away and all that kind of stuff, like it
Yes.
just stopped becoming
Yeah.
like that focal holiday for us. But it's still, actually, Allison still loves it a lot. She like looks forward to it like no one's business. And she cooks all of the stuff. Like she's so good.
Oh,
So,
I love that. I love it. I love all the Thanksgiving food, all the things. I have a small family, so it's not like a huge thing, but it's nice that we all get together and everything.
so there was a trivia question that I wanted to ask you. We're going to, don't let our listeners, we're going to get to our episode eventually, but hold on. So there's a trivia question that was this morning, and it was saying, what is the term that is within like the last 10 years been the most Googled term around this time of year?
I don't know. I was going to say something about a turducken, but I don't know.
See, that would have been a good guess too. Or like, someone's recipe for a turkey
Right,
or
yeah.
whatever, Martha Stewart's, whatever.
Yes.
Right? No, it's Friendsgiving.
Oh,
Yeah. You seem disappointed by that.
a little bit, because I'm like, I don't know. I feel like Friendsgiving, like the name explains itself. I don't know.
Well, it is, but I think more and more people are not going home for the holidays and things like
Oh,
that.
true.
And so,
Yes.
and then like college kids, if
Yeah.
they're staying, and doing their own Friendsgiving thing, or if you're transplanted to a new city or whatever.
Yep. Yeah.
So I guess that's
Friendsgiving. Yeah.
yeah.
A lot of my students are doing Friendsgiving things, and
Yeah.
I get
So-
it. So that's cool.
Okay, well, we have a great episode for you listeners. Unfortunately, I wasn't able to be on this one, but Annie took control and just did a whole interview and stuff
It
and
was
things.
great. Yes, Andrew, you were missed, but we had a great I had a great conversation with Lynn Pencek about implants, and we were talking about new practice guidelines around implants and what was once recommended may not be recommended anymore. And I feel like my perspective on implants certainly shifted a little bit, as far as even something as simple as not probing implants every single time and getting baseline measurements on implants and going from there and looking at other clinical markers. And so it definitely made me like reconsider like how I view implants and how we treat them. So it was a really great conversation. She's very knowledgeable about implants.
Do your students see implants in like for the patients that come in, and like it's more and more prevalent now? Yeah.
Yeah, and that was the thing is, yeah, our students do see implants, and right now our guidelines for implants with students is they use a plastic probe to probe the implants, and then they have the titanium scalers. And so, but it was interesting listening to Lynn's perspective as far as she doesn't necessarily feel like implants need to be probed every time, because it could be altering that like delicate membrane around the implants, and so probing them every time could potentially be doing more harm than good, versus just taking a PA
Interesting.
every year and looking at the biofilm and looking at the tissue, and all those things are more important than just probing it every time.
Which, by the way, it makes a lot of sense because as we have new ways of measuring health, that's not just a
Right.
metal rod stuck in the
Right.
gums.
Exactly.
We should probably start leveraging some of those. But well,
Exactly.
that's exciting. Really looking forward to this episode. I'm gonna have to listen back to it once it actually airs and I download it onto my feed. But so also everyone, we are currently looking for more guests and more topics. And so if you have any suggestions of people that we should interview, make sure you reach out to one of us and let us know. We'll get them on the show as soon as we can. And I think that's it.
Great.
Is there anything else?
I don't think so.
All right. Well, enjoy this episode, everyone.
A tale of two hygienists.
Listeners, welcome back to the interview portion of the podcast. I am joined today by Lynn. We're so excited. We're going to be talking about implants today. Lynn, thanks so much for being here.
Annie, thank you so much for having me. I appreciate this.
Great. Okay.
Yeah.
So today, yeah, like I said, we're going to be talking about implants. We're going to be talking about changing protocols for implants, and maybe some things that we once recommended may be considered harmful to the patient now. So, Lynn, why don't we start by talking about probing with implants?
Oh, gosh, yeah.
Should we be probing? Should we not be probing? Let's talk about that.
You know, I'm going to tell you, honestly, depending on what resources you talk to and the passion of the person giving the information, you're going to get different answers. So
Sure.
I don't have a solid yes, no, black, white answer, but let's keep in mind that when we probe natural teeth, you have fibers, periodontal ligament, going from the cementum to the keratinized tissue. And when you probe a natural tooth, the probe is going to interact with the sulcus of the pocket, and you'll have these horizontal fibers preventing you from probing deeper. With a dental implant, you have vertical fibers. They're called hemidesmosonal fibers, and they're vertical. So if you were to take your hair and put a ponytail holder around it, the fibers are kind of in that same vertical motion. The soft tissue around an implant is adhered onto the implant. Think like your cuticles. It's a soft tissue attachment. It's delicate. And you can, with pressure, just like your cuticles, detach or move the soft tissue attachment. So we talked about the horizontal fibers in natural teeth. The vertical fibers means that your probe may fit between the vertical fibers, and you may actually go through the attachment and interact with the bone. So we do need probe readings for a baseline of what is a normal probing depth, but we shouldn't feel compelled to probe every single time we see our patients.
Oh, interesting.
And,
Okay.
that me as a hygienist, boy, that's tough. I want to know,
That
is
is
the
tough.
tissue firm? Is it going to bleed when I go in there?
Right.
But we
right.
can actually cause more damage than good aggressively probing around implants.
Okay.
So first probe readings should happen 6 months to a year. Longer's better, in my opinion. Okay, because we want
After the implant is
and
placed.
the implant's been placed and restored.
Okay.
So here's the difference, and
restored, okay.
we have to really think about when we put the implant in and we place the abutment and the crown. The soft tissue will mucal integrate. This is a new term. We didn't always call it mucal integration. We'll have this soft tissue
Yes.
attachment onto the abutment, and we want that soft tissue attachment to be mature. So we want to wait that 6 months to a year. Longer's better. And then we want to get baseline readings. And with natural teeth, 1 to 3 millimeters is considered healthy. Once we get to 5 millimeters, we consider it to be diseased. But that's not always true with implants. You can have deeper pockets, and it's still considered healthy, because part of what we're
Absolutely.
doing with implants is trying to create aesthetic interproximal areas. So you can have a deeper pocket. You could have a 5. You could have a 7 millimeter pocket, maintained healthy, clean, and the tissue is healthy. So when we're probing, first probe readings, we want to work with a very light touch. Unit of measurement is 0.25 Newton centimeters of pressure. I know. Like you and I didn't learn this in hygiene school. What does this mean? What does this mean?
Right.
So the way I came to understand how much pressure, 0.25 Newton centimeters, when the implant's placed, they torque. They use a torque device to measure the amount of pressure, how much pressure can we put on, and the implant doesn't move in the bone. All right, so this is where they do the test for primary stabilization. Do we have enough force and pressure that the implant's considered secure in the bone? So 75 Newton centimeters is a lot of pressure. And you hear the ratcheting in a torque wrench when they're doing the torque test to see if it's secure in the bone. To place a restorative, they're torquing to about 35 or 15 Newton centimeters. And this is when you watch with the torque wrench. It's a very light pressure. So less than a Newton of torque value of pressure.
So 0.25 is the pressure?
The way I visualize it is I take the probe, I insert it in the pocket, and I just watch to see where does it fall. I'm not applying any pressure to see if the tissue blanches. Just how far does the probe fall into the space? This is how I see it. So we want to see what are our original probe readings, what's considered the norm for this case. And if the patient comes back and we disclose and there's no biofilm, so we're thinking guided biofilm therapy. If the tissue looks pink and healthy, we disclose. We don't see biofilm around the tissue. We look at x-rays. We don't see change in bone. I don't feel compelled to probe that patient.
Okay.
Boy, and as a hygienist, you want to go in there and you want to probe. I mean, we want to do this, and you almost feel like you're not doing your job, not probing.
Right.
But if you're going in and aggressively probing every time you see this patient, you could be detaching the buccal attachment. You could be causing more trauma than good. So now there's another school of thought, different party, that may say, we do want to probe. We do want to know if it bleeds when we probe. So, and it's hard to give a yes or no answer on whether we do or whether we don't. But if it looks healthy.
So you're really going off of those clinical parameters as far as if it looks healthy. When you disclose, if there's no biofilm around it, looking at the radiographs.
Yes, no evidence.
Do you recommend taking, are you pretty much recommending annual PAs around the implants to evaluate the bone levels?
Annual PA, annual vertical bite wing. And sometimes you're going to see a different view, a different angle, better threads with the bite wing view versus the periapical. And the goal is, where is the implant in the bone? Can you see the threads? So you want to be able to count the threads. If there's bone loss, are we consistent counting the number of threads of bone loss there is? If there's, is the bone right at the platform, the top of the implant? So when implants are placed, you'll listen to the surgeon explain, you want to place the implant subcrestal. You'll hear 1 to 2 millimeters, 2 to 3 millimeters, because they do expect some bone loss, remodeling, at initial placement. They do expect it.
Right.
And with the original parallel implants where the connection was flat to flat, you would find an expectation of bone loss in the first year. And with the platform switch and the bone now goes to the table at the top of the implant, the expectation is less bone loss because of this new design for the implants. So one of the goals is 0 bone loss in that first year. So you'll find that we're going to take an annual bite wing and annual periapical, but that first year, patient may come in 3 times. You may take a periapical each visit to confirm we're not getting bone loss.
Okay. So that first year after a patient has an implant placed, you want to take x-rays every time they come in.
That's what I would see. Now, you'll see a periodontist maybe more precautious and take more x-rays, and you may find somebody more of a prosthetic background may not take as many x-rays. And it's just different school of thought and how they were trained.
Absolutely.
So you'll people do different things. It's been interesting working with the different specialties. And there is no right or wrong answer. But if the tissue's healthy, looks good, they may pass on the x-ray. But I found the periodontist I worked for was every time the patient's in, we just want to confirm.
Right. Okay. That makes sense. Do you find it challenging?
Mm-hmm.
Right. I'm sitting here wondering, how do we effectively, because I know you were saying we want to get baseline probe probe depths. How do we necessarily do that though? Because if a patient has come to us that has had that, if they've had their implant for X amount of years, would we consider that the baseline probe depth and then go from there? Or you
Great
know what I mean? Like
question.
if we don't see that patient like right after they get the implant
Yeah.
placed, how do we handle that?
Patients move around,
Yeah.
patients change practitioners, these things happen. So if they're new to you in the practice, it makes sense to have those baseline probe readings at first
Okay.
visit. It makes sense to do that. You had another question there, and I drew a blank on it.
That's okay. Yeah, I was just curious what the protocols look like for a hygienist as far as getting those baseline probe depths if they've had the implant for X amount of years, or if they're new to the practice, or if we don't see them right after they get the implant placed.
And then how healthy is the patient? Is there biofilm? Is there inflammation? And
Sure.
so if we do know there's a disease state and we go in, we probe, we may cause trauma. So there's a
Right.
school of thought, look, it's inflamed. We know it's inflamed. Let's work on home care. Let's place an antimicrobial. Let's bring the patient back in 2 weeks and see if it heals up. Instead of probing, we're going to confirm there's disease. So
Right.
if we have
Okay.
evidence, we should do some kind of intervention. Start with home care.
Okay.
What are we doing? What can we do better? I love to use the terms of good, better, best. You're doing
Okay.
good. We need to do better. Okay, let's try the
Right.
water pick, and really
Right.
go over what they're doing. Placement of an antimicrobial like a Cervatec, the chlorhexidine diconate varnish, has a long-term latent effect of releasing. It's a polymer, so it releases the antimicrobial over a period of time, over 3 months. So placing an antimicrobial and bringing the patient back 2-3 weeks for evaluation, do they look healthier? I would say
Okay.
that'd be a safer time to probe than when they're inflamed.
I
Now,
see. Okay.
we saw somebody yesterday, and we knew that there was insufficient buccal bone on this patient. We knew that this implant was a failing implant. And the discussion with the patient is ideally the implant should be taken out. We should graft. We should place the implant in a better position for survival. The patient's in his 80s, and he has said, let's just let it ride. So the patient's decision, less than ideal, but we all are understanding what we're doing. So from the facial aspect, I can't see facial bone loss with a bite wing or a periapical. So we do want these patients getting CBCT exam, 3-dimensional x-rays to see bone levels. But in this case here, it looked funny from the lingual surface. Previous history, no pocketing on the lingual. I looked at it. I thought it was funny. I wanted to test it. I did probe. It dropped down 9 millimeters. So in this situation here, it didn't look inflamed, but the tissue didn't look right. When I sprayed air, I could see it reflect. And when I squeezed, I got some exudate. So I knew something was going on.
Absolutely.
And in this case here, we had to change the dialogue with the patient.
Sure.
And it's like we knew that we knew we had less than ideal situation in the facial surface, but there's infection on the lingual. And this
Right.
is a patient who comes to the GP, and we need to send the patient back to the periodontist. So we had to have this, the heart-to-heart conversation. We had a
Right.
good run. We don't want you to have an infection that, I love to
No.
term an infection that explodes. We want to prevent that from happening. And so we asked the patient, we wanted to refer the patient back to the periodontist in that situation. Yeah.
Okay. So let's talk instrumentation a little bit, because you were talking about probing and you mentioned a little bit about guided biofilm therapy as far as management of implants. So let's talk about that as far as what you recommend probing wise, instrumentation wise, therapies. Let's get into that.
Yeah, let's continue with probing. And
Okay.
again, different schools of thought. I have read we are safe to probe with titanium stainless steel plastic probes. I have read that. I do hear some theories working with a plastic probe is best because it gives a little flex if you're applying too much pressure. So,
Okay.
choose wisely, use a light pressure when you're probing.
I have a question about that, because I've heard, and this could be schools of thoughts too, I've heard that implants that have failed, when they've looked at them like under a microscope, they've seen like tiny specks of plastic from the plastic
Yeah.
probe or plastic scalers. What do you think about that?
So plastic is not biocompatible. So, the theory of probing is you're placing it in and you're not engaging and dragging it across. Where with instrumentation, if there was calculus, you're engaging and you're trying
Okay.
to wedge off.
I see. Okay.
So,
So a probe is fine. Okay, that makes sense.
and if you're probing around an abutment, we're not engaging in the rough surface of an implant. So let's go back one more step. Materials, crown, smooth, porcelain, zirconia. Abutments, smooth, titanium or zirconia. So abutments are made of a biocompatible material for that soft tissue attachment. We want to see the biological width on the soft tissue attachment on the abutment. The body will want to heal. If there's not enough room for biological width, this is where we may start to see recession, and we may start to see the biological attachment on the implant. Implants are rough, but some implant collars have smooth collars. So you'll see a machined collar where the top 2 millimeters are smooth. You'll see a partially machined collar where just the tabletop of the implant is smooth. You'll see implants where the first 5 millimeters are smooth. You'll see implants where there's lots of threading and the anodized or the titanium dioxide layer. So you'll see implants are both smooth and rough. And there's thousands of different designs. The goal is to get the soft tissue attached to the smooth, the bone will attach to the rough surface. But if we have insufficient biological width, you may find apical migration, where the body's trying to heal itself and work its way down. And then we have the soft tissue attaching onto the rough surface. And that's not the best situation. So if we're probing on an abutment, it's a smooth surface. So this is why we don't want to probe so much either, because what we were saying. So let's move on with that. And instrumentation.
Yes.
If we're healthy, absence of biofilm, patient has good home care, not a lot of inflammation around the soft tissue, we don't need to take a curette and explore around the implant. And when I work on natural teeth, I will work with my Montana Jack. I will work with my Gracie, my extended shank 1314. I will explore around with a stainless steel curette and all natural teeth to see if I find anything I need to remove. On implants, we don't want to be instrumenting unnecessarily. And the reason here is we're seeing a phenomena become more and more into the literature now. When you take a plastic instrument against the rough surface of the implant, there is evidence of leaving shards of plastic behind. Sue Wingrove, with the research that she's done, has demonstrated that plastic's being left behind on the smooth surface of an abutment. So we're now moving away from plastic as a whole. And then if you talk to hygienists, it's not efficient. You can't effectively remove anything with it. So what we were told to do in the 80s and 90s, the implants were made different back then. They were more machined. They weren't the rough surfaces we work with now. So what I was taught when I graduated in the 80s was to use plastic because they didn't want to damage the implant surface. I got a thought. I will bring back to it because I don't want to jump around too much. But you're going to see these meta-analysis where they review many articles. And they will demonstrate that use of plastic instruments are least damaging to the implant surface. So I always like to use the err on the side of caution, do the greatest amount of good with the least amount of damage.
Right.
And so here in my generation, we were told scale with plastic instruments. We know it doesn't work. There's sometimes cement. Sometimes they'll use cement. Sometimes they'll screw retained the abutment, the crown onto the implant. Excessive cement needs to be removed. Pretty much impossible to remove with a plastic curette. So then they'll suggest a PEEK curette or a graphite curette, and you'll see all these different materials. So this is all very old school mentality. We now know all instruments will leave some kind of residue of its metallic, of its plastic behind. So you really do want to use a biocompatible like material on the implant surface. So if you're going to engage and you're going to scale a titanium instrument, we'll leave a biocompatible trace behind, titanium on titanium. You want to make sure that your instruments are of a lower Rockwell hardness in compared to the implant. So the implants are soft, so we have a certain level of Rockwell hardness that we should be working with. Now, cement requires some strength to remove, so you shouldn't feel guilty, compelled that you may cause damage because the residual cement will attract biofilm. Leaving the cement behind will be more of a problem. If there's biofilm, we may want to work with a desiccant prior to working with a titanium instrument. There's some concern here. I'm reading really nice research about desiccation therapy being effective with peri-implantitis. I'm also reading about use of acids on titanium can cause corrosion. So my brain right now is thinking, if I have a patient show up with a lot of calculus, with infection, to use the desiccation therapy, but not use it every single time the patient comes in. So right now, I'm thinking a one-time use is not a bad thing. I'm concerned with that patient who just doesn't understand how to brush, especially those implants in the lower anteriors. So I'm still, I think it's a great thing. I just want to see some in vivo in glass studies with the
Sure.
desiccant on the titanium to see
Sure.
are we safe with multiple uses. But right now they're
Definitely.
using desiccation on implants and the results are
Mhm.
compelling. So I'm
Right.
seeing good things.
Definitely. I just recently wrote a research article about desiccation therapy and the benefits of desiccants, and so I'm glad that you jumped in and talked about that with implants. So I'm really encouraged to hear that. I feel like desiccants are something that are pretty simple to use, chairside.
I see it as the future of dental hygiene. Now that we know this is a
Right.
disease of biofilm, this is biofilm science, and desiccant works effectively with biofilm. This makes so much sense.
Right. So what do you think about, as far as if we're talking about biofilm control, what about GBT and guided
Wow.
biofilm therapy with
So,
implants?
least amount of damage, greatest good with least amount of damage. Can we remove the calculus with guided biofilm therapy? Can we remove the calculus with ultrasonics? And so when Susan Wingrove wrote her protocol, the protocol was different than what I was taught in the 80s. And her protocol is start with airflow, start with air
Okay.
I always want to say air abrasion, start with air polishing with glycine or erythritol. Now,
Yep.
I'm of a certain generation. I work for a few different dentists of a certain generation. I also live right
Okay.
by, I live by York, Pennsylvania, so I live near Densply. I see a ton
Okay.
of the original Prophy jets in these offices. I'm of a certain generation.
Yes.
So, and these Prophy jets, the original generation, were used with baking soda.
Yep.
So baking soda we have issues with on implants. We don't want to use
Right.
baking soda on implants. The pH is very basic. That can contribute to corrosion. There are case studies showing implant failure because of use of baking soda. It's a very large granule. I'm afraid of it causing texture damage to the
Mhm.
titanium
Mhm.
dioxide surface. So we want to make sure that the air polisher we're working with can be used with erythritol or glycine. And the nice thing is
Okay.
all the new generation air polishers are. So we now know
That's great.
choose the proper material to work with on implants. If you have old equipment in your offices and it still works, don't use it on implants. You may need a second air polisher that you can use the appropriate material, appropriate medicament in. So, and it's kind of, it's interesting having that conversation with doctors. And
Certainly.
there's the ultrasonic tips. Again,
Okay.
I live near I live near York. I see a ton of the original blue plastic tipped
Yep.
ultrasonic tips. Lots of offices have them because it was the original, this is your implant tip. Replace the blue
Mhm.
plastic tip per patient. And when I first started asking questions and I would talk to hygienists about their implant tip, that I hate it. It's like, because it falls off. What is it? It leaves plastic behind. So again, that tip was designed for the original implants that were machined before the introduction of the titanium dioxide corrosion layers. So if it was bought before 2000, what we were doing with implants was different. So we know that that tip should be retired and be replaced with a tip coated with PEEK, polyether ether ketone. PEEK is a biocompatible material. So if it is left behind on the implant, it's not going to cause any type of reaction. So I live by Premier. Premier has a PEEK tipped ultrasonic that fits into a standard ultrasonic. So
I didn't know
it
that.
could be replaced. It could be replaced. It's kind of interesting that both product managers were
Yes.
classmates of mine when I started this
Oh
project.
my gosh. Wow. How funny.
And it was interesting when we talked about the original Densply tip, only use it on the crown. Don't use it on the abutment. Don't use it on the implant. So, and in that case of if the tissue's up to the crown, the attachment, the biological attachment is at the abutment to the crown, the thought was you could use it for maintaining healthy implants. But we now know that the attachment can be lower, the attachment can be on the implant. So we want to make sure that we're choosing the right tip for the right situation. Where are you on the implant? Whether or not it's safe to use. So you'll find that direction of, can we get something that we can use safely on all? Yeah.
I didn't realize that Premier had that tip. That's really encouraging and exciting to hear. So we're getting near the end of our conversation. I want to round it out by having you talk about home care for implants.
Home care for implants. I'd like to give the patient a lot of options, see what they like using, see what they're good at using. So you have that period of time between the implant being placed and the implant being restored. And I want to go over what works well. So there's a appointment where the patient comes in to have the sutures removed. It's a post-op. Start to go over home care with the patient then. If they're still healing, we may have the patient just work with a Q-tip dipped in an antimicrobial and dab around the area
Okay.
as it's healing. We may have the
Okay.
patient just rinse and not brush, and then as the tissue's healing, introduce. Some people will bring in a water pick using it on lower setting early on. Some people will bring in a surgical brush. And then as the healing process, we start having the patient work with interproximal brushes when the restoration's placed. Flossing, you'll find some people say it's okay to floss. Some people say don't floss. We want to make sure that we're not using woven floss because woven floss can leave little shreds behind. Those shreds will
Right.
stay in the pocket. They collect biofilm. They can contribute to a periimplantitis. I'm a big fan of proxy brushes. Make sure that
Okay.
the wire's coated with a plastic on there. Yeah, I like to go over all the different tools. There's universal brushes that have contra angles so you can get in and underneath the height of contour of the crown. So Tepe has this really great implant care kit, and it's all the different
Great.
brushes. And I like to open it up and show the different brushes to patients, show them how to work with it, watch how they're working, see what works well for them, and let them choose what works well. And when they come back for evaluation, if they look great, I say you're doing fantastic. And if they don't look great, hey, let's revisit and bring in. But water flossing, I think water flossing is fantastic. Start with at
Great.
the low setting, and then we'll bring our settings up as we work with. I find that there's sometimes a school of thought. I get different opinions. I find sometimes an office is very pro with the water flossing, and I find sometimes they're more leisure. They're more they want to wait. They want to wait for it to heal longer before they introduce the water flosser. You always get these polar opinions on everything. But
Right.
yeah, there's research demonstrating the use of the water pick's more effective than flossing. So I just think
Right.
it's a great tool. And then they have this really cool U-shaped tip that if the implants are in the lower anteriors, it gets in and underneath in that area where we
Great.
see the buildup the most. So there's some great
Good.
tools out there.
Yeah. Wonderful. Okay. Great. Well,
Alcohol-free mouth
Lynn,
rinsing.
thank you so much for sharing all this wonderful information and giving us a little bit more guidance with implants. It's so interesting. Like we said, what we once thought was recommended, now things are changing. But I mean, that's dentistry, and I'm excited that there's always new information and research coming out to guide our
And it will
practice.
continue
So,
to change. It will continue to change. Absolutely.
if our listeners want to get in contact with you, how can they find you?
So I am on social media, on LinkedIn. You will find me under Lynn Pencek. If you go on Facebook, you'll see Lynn Pencek Mini. That means I show my husband and my basset hounds a lot more on my Facebook page. I had a website. My LLC is Practice at Your Best, and my email is lynn@practiceatyourbest.
Great. And we'll make sure we put this all in the show notes. Again, thanks so much, Lynn, for your time today. Really appreciate it.
My pleasure. Thank you so much.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.